Bismillahirrahmanirrahim. I am Dr. Isma and we shall be continuing with tubular reabsorption and tubular secretion. In the previous lecture, we did various mechanisms of tubular reabsorption, including the active and the passive mechanisms. Today we shall be doing transport maximum for substances that are actively reabsorbed by the tubules. You can see the various substances that are actively reabsorbed by the tubules, and these substances show a transport maximum. In this slide, you can see the transport maximum for substances that are actively secreted by the tubules. What is transport maximum? Transport maximum is the limit to the rate at which solute can be actively reabsorbed or secreted. In other words, for actively reabsorbed substances, it is the maximum rate at which that substance can be reabsorbed or secreted. For example, in case of glucose, 375 milligram per minute, when all the nephrons have reached maximum capacity to reabsorb glucose, is the transport maximum. This limit is due to the saturation of specific transport systems which are involved when the amount of the solute delivered to the tubule, which is known as the tubular load, exceeds the capacity of the carrier and the specific enzymes which are involved in the transport process. For glucose, the tubular load, as we all know, is calculated as GFR multiplied by the plasma concentration. So with the GFR of 125 milliliter per minute and the plasma concentration of 1 milligram per milliliter, the glucose tubular load is 125 milligrams per minute. Normally, glucose does not appear in the urine because all of the filtered glucose is reabsorbed in the proximal tubules. However, when the filtered load exceeds the capacity of the tubules to reabsorb glucose, urinary excretion of glucose does occur. So the threshold for glucose will be the plasma concentration of glucose at which glucose first begins to be excreted in the urine. The threshold for glucose comes before the transport maximum is reached. And in case of glucose, the threshold is approximately between 180 and 200 milligrams per deciliter. Note in this diagram that when the plasma glucose concentration is 100 milligrams per deciliter, the filtered load is normal, which is 125 milligrams per minute. There is no glucose in the urine. However, when the plasma concentration of glucose rises above 200 milligrams per deciliter, the filtered load increases to 250 milligrams per minute and a small amount of glucose begins to appear in the urine. This point at which the glucose begins to appear in the urine is known as the threshold for glucose. Why is there a difference between the threshold and transport maximum for glucose? One of the reasons is that not all the nephrons have the same transport maximum for glucose, and some of the nephrons excrete glucose before the others have reached their transport maximum. The overall transport maximum for the kidneys, which is normally 375 milligram per minute, is reached when all the nephrons have reached their maximum capacity to reabsorb glucose. This is another slide to help you understand the concept of transport maximum of glucose. If you can follow the pointer, so Splay is the deviation of the actual reabsorption curve from the ideal or the predicted curve, or it can be said that it is the difference between the threshold and the saturation of the renal carriers, or in other words it can also be said that it is the concentration difference between maximum renal reabsorption and the appearance of glucose in urine. The reason for splay is the heterogeneity of the nephrons, that is, not all the nephrons have the same transport maximum. Glucose excretion in the urine of a healthy person is different from that of a person with diabetes mellitus. In case of a healthy person, the plasma glucose level almost never becomes high enough to be excreted in the urine even after having a meal. However, in uncontrolled diabetes mellitus, the plasma glucose may rise to a high level, causing the filtered load of glucose to exceed the transport maximum and resulting in urinary glucose excretion. The reason that actively transported solutes often exhibit a transport maximum is that the transport carrier systems become saturated as the tubular load increases. Some substances, however, that are passively reabsorbed do not have transport maximum. This is basically because of three reasons. Number one, electrochemical gradient. Number two, membrane permeability. Number three, time for which the solute remains within the tubule. Transport of this type is referred to as gradient time transport because the rate of transport depends on the electrochemical gradient and the time that the substance is in the tubule, which in turn depends on tubular flow rate. An important example is sodium reabsorption in the proximal tubule. Although it is actively transported, but it still shows characteristics of gradient time transport because the rate of transport depends on electrochemical gradient, the time that the substance is in the tubule, and the tubular flow rate. Why sodium transport in the proximal tubule does not exhibit a transport maximum? The reason is that other factors limit the reabsorption rate besides the maximum rate of active transport. In the proximal tubule, the maximum transport capacity of basolateral sodium-potassium ATPase pump is usually far greater than the actual rate of net sodium reabsorption, and also a significant amount of sodium transported out of the cell leaks back into the tubular lumen through the epithelial tight junctions. Now, the rate at which this back leak occurs depends on several factors. Number one, the permeability of the tight junctions, and number two, the interstitial physical forces which determine the rate of bulk flow reabsorption from interstitial fluid into peritubular capillaries. This means that the greater the concentration of sodium in the proximal tubules, the greater would be the reabsorption rate. And also it means that the slower the flow rate, the greater would be the reabsorption. So, sodium transport in the proximal tubules obeys mainly gradient time transport, which means that the reabsorption rate is directly proportional to the concentration of sodium in the tubules. Like I said earlier, the greater the concentration of sodium, the greater would be the reabsorption rate. And number two, the reabsorption rate is inversely proportional to the flow rate. That means that the slower the flow rate, the greater would be the reabsorption rate because more time would be available for reabsorption. Sodium reabsorption in proximal tubule versus distal tubule. We have already seen that in the proximal tubule, sodium reabsorption does not exhibit a transport maximum but follows gradient time transport because of back leak of sodium into the lumen. However, in more distal parts of the nephron, especially the distal tubule, the epithelial cells have much tighter junctions and transport much smaller amounts of sodium. In these segments, sodium reabsorption does exhibit a transport maximum similar to that for other actively transported substances. Also, this transport maximum can be increased by certain hormones, for example, aldosterone. Passive reabsorption of water by osmosis is coupled mainly to sodium reabsorption. When solutes are transported out of the tubule either by primary or by secondary active transport, their concentration tends to decrease inside the tubule while increasing in the renal interstitium. This creates a concentration difference which causes osmosis of water in the same direction that the solutes are transported, meaning from the tubular lumen to the renal interstitium. Some parts of the renal tubule, especially the proximal tubule, are highly permeable to water, and water reabsorption occurs so rapidly that only a small concentration gradient for solutes across the tubular membrane develops. In the proximal tubules, a large part of osmotic flow of water occurs through the so-called tight junctions, either through paracellular route or through the transcellular route. And the reason for this is that the junctions between the cells are not as tight as their name implies, and they permit a significant diffusion of water and small ions like sodium chloride, potassium, calcium, and magnesium. So as water moves across the tight junctions by osmosis, it can also carry with it some of the solutes, a process which is known as solvent drag. And because the reabsorption of water, organic solutes and ions is coupled to sodium reabsorption, changes in the sodium reabsorption significantly influence the reabsorption of water and many other solutes. There is a variation in the permeability of tight junctions and surface area of the epithelial cells in the proximal and the distal parts of the renal tubule. We have already seen that the tight junctions in the proximal tubule are highly permeable to water and significantly permeable to most of the ions like sodium chloride, potassium, calcium, and magnesium. And also the epithelial cells have a much increased membrane surface area. In the more distal parts of the nephron, however, especially beginning in the loop of the Henle and extending all the way to the collecting tubule, the tight junctions have become far less permeable to water and solutes, and the epithelial cells have also a greatly decreased membrane surface area. So water cannot move easily across the tight junctions of the tubular membrane by osmosis. However, antidiuretic hormone greatly increases the water permeability in the distal and the collecting tubules. So we can see that the movement of water across the tubular epithelium can occur only if the membrane is permeable to water, no matter how large the osmotic gradient. In the proximal tubule, the water permeability is always high and water is reabsorbed as rapidly as solutes. In the ascending loop of Henle, water permeability is always low, so almost no water is reabsorbed despite a large osmotic gradient. Water permeability in the last part of the tubules, which is the distal tubules, collecting tubules and collecting ducts, can be high or low depending on the presence or absence of ADH. So a more important parameter for movement of water across the tubular epithelium is permeability to water and not the osmotic gradient. This is just a table showing you the comparison of permeability to water in different parts of the renal tubule, and I have already talked about this in the previous slide. Reabsorption of chloride and urea and some other solutes by passive diffusion. When sodium is reabsorbed through the tubular epithelial cells, negative ions like chloride are transported along with sodium because of electrical potentials. That is, transport of positively charged sodium ions out of the lumen leaves the inside of the lumen negatively charged compared with the interstitial fluid. This causes chloride ions to diffuse passively through the paracellular pathway. Additional reabsorption of chloride ions occurs because chloride concentration gradient develops when water is reabsorbed from the tubule by osmosis, thereby concentrating the chloride ions in the tubular lumen. Thus, active transport or reabsorption of sodium is coupled to passive reabsorption of chloride by way of electrical potential and also by way of a chloride concentration gradient. Chloride ions can also be reabsorbed by secondary active transport, and the most important of the secondary active transport process for chloride reabsorption involves co-transport of chloride with sodium across the luminal membrane. Urea is also passively reabsorbed from the tubule, but to a much lesser extent than the chloride ions. As water is reabsorbed from the tubules by osmosis coupled to sodium reabsorption, urea concentration in the tubular lumen increases. This creates a concentration gradient which favors the reabsorption of urea. However, urea permeability is far less than the water permeability, especially in some parts of the nephron, especially in the inner medullary collecting ducts. Passive urea reabsorption is facilitated by specific urea transporters. However, even then, only about half of the urea that is filtered by the glomerular capillaries is reabsorbed from the tubules. The remainder of the urea passes into the urine, allowing the kidneys to excrete the large amounts of waste product of metabolism. Another waste product of metabolism, creatinine, is an even larger molecule than urea and is essentially impermeant to the tubular membrane. Therefore, almost none of the creatinine that is filtered is reabsorbed. So, virtually all the creatinine filtered by the glomerulus is excreted in the urine.